Let me briefly introduce Valerie and Press and Sarah Gray. Valerie Press, MD, MPH, is an associate professor of medicine and pediatrics, medical director of the Care Transition Clinic here at the University of Chicago, and an associate junior faculty scholar at the Bucksbaum Institute. Valerie currently serves as principal investigator for 2 research project grants, R01s, from the National Institute of Health, National Heart and Lung and Blood Institute, and the Agency for Healthcare Research and Quality, and also is a principal investigator on an innovation award from the American Lung Association, awards which, or studies which are focused on improving care for patients with COPD by utilizing patient and system-centered interventions to reduce revisits to the emergency department and even to the hospital. Dr. Press has authored or co-authored nearly 100 manuscripts in peer-reviewed journals, and in addition to serving as an editor of Chronic Obstructive Pulmonary Disease, Dr. Press is also an associate editor for the Journal of Internal Medicine. It's a delight to have Valerie Press join us. Let me say about Sarah Gray, who earned her medical degree at the University of Michigan Medical School and then completed her clinical training in internal medicine residency here at the University of Chicago, after which Dr. Gray served as chief resident and clinical instructor for the internal medicine residency program. Currently, in her research years for pulmonary and critical care fellowship, Dr. Gray is also pursuing a master's in public health. Her primary research interests focus on care disparities in obstructive lung disease, particularly gender disparities, and the management of asthma during pregnancy. The title of the talk that Dr. Press and Dr. Gray will now present is a national partnership with the Chronic Obstructive Pulmonary Disease, the COPD Foundation. Dr. Press and Dr. Gray, please come on board. And people, please enter any questions in the Q&A section for Matt Sorrentino. Thank you. Hi, Valerie.
Hi, thank you so much for that lovely introduction, and hoping it's okay to speak on behalf of Sarah. We're both so honored and thrilled to be able to talk with you today at this symposium, and want to share my congratulations for the 10th annual symposium. I also want to note it's tough shoes to follow. Dr. Peak, that was amazing. Again, just thrilled to be here. And if I may, just one more personal note. Having been the caregiver of a family member in the last 2 days dealing with a medical emergency with unfortunately some poor communication, the focus of this institute on making patient and provider communication better is just the most salient aspect of healthcare. And I loved the quote that Dr. Peak mentioned about not being able to know, about how important it is for patients to know how much we care before we can actually provide the care. So just that personal note, but excited and thrilled to talk with you today about our project that is in partnership with the COPD Foundation. And just for a quick moment, if people haven't heard about this foundation, they're really, really spectacular. They were initiated by an individual who had COPD, and then it's supported and led by patients and family members and advocates for patients. And they are really focused on trying to improve the lives of those who are living with this disease. And they are trying to advance initiatives that expand services and speed innovations. And they are hoping for, of course, a cure. In the meantime, why are we personally focusing on COPD? Well, it is one of the leading causes of death. And in addition to death, it is also a leading cause of morbidity, day-to-day problems with symptoms and low quality of life. And it's notably one of the most common reasons to be readmitted after an initial admission. There are a number of factors that come together for these high rates of admissions. But one of the things that is really disturbing is that we do actually have medications, both rescue medications and controller medications, that can really help patients control their disease and live better quality lives. But in several studies that our team has done and across, honestly, the world, we know that patients just don't know how to use these medications effectively to get those medications into their lungs. And that is just one of the many factors, of course, that lead to readmissions. So one of the interventions we've been looking at is a very patient-centered communication forward strategies, where you tailor the intervention in the moment by understanding first, what level of understanding does the patient have in terms of using these important medications? And only after understanding first where they're starting from, do you then provide education, demonstration to them to try and help them advance their skills. And again, you don't stop there. You use cycles of teach back or show back to then understand their learning process, as this is a skill-based procedure to understand how to use these medications. And what you can see here in the center of this diagram is a checklist. And so we've been studying how can we understand in the moment the steps that patients need to take and whether they're learning them, and then communicate effectively, tailored to that patient and their experience right there in the moment. We have incorporated this Teach-to-Goal strategy as part of the COPD readmissions reduction program, of which I'm one of the co-directors, and we have been using this for years. But as one of the questions that came up earlier in the Q&A with Dr. Peak around chronic disease, the pandemic stopped in our shoes the ability to provide this kind of education face-to-face. And so we started to think about how we could start to provide education using virtual and technology strategies, but while also not further distancing patients who couldn't use those technologies. And so Dr. Gray in a moment will talk to you about our actual strategy, but this was sort of the basis educational strategy we wanted to employ, but not always with patients here in front of us at the clinic or hospital. This is just a note that we don't expect perfect technique. We want the medicine to get into their lungs, and there's a little wiggle room in this checklist. So that's just a reminder for me to tell you that. Just a little bit of data, and then we'll move on. And so we wanted to let you know that this patient-centered and this iterative approach to teaching using Teach-to-Goal is effective, and more effective than simply using other strategies such as telling patients what to do, not just giving a handout, but actually telling them. And the light blue line here are those patients who received that type of brief instruction where we read out loud the steps, but we didn't use that show me first and then let's teach you and go back and forth. So if you see the first dip here from the pre to post, I think it's quite demonstrable that if you follow the black line, that about 90% of patients in this cohort were not using their inhaler correctly initially. They received the Teach-to-Goal, the multiple rounds of education, and immediately after, only 10% were still having difficulty, which is quite an impressive drop. But what you might note if you've read along on the graph is that those two groups came together at 30 days and 3 months. And so we recognize that we need to have, even ahead of the pandemic, ways to reach our patients in multiple settings, possibly including their homes, that are effective ways to teach patients and reteach patients these important skills. And just as a reminder, the inhaler technique is really pivotal to helping patients get that medication in their lungs so that they can lead healthy, high quality lives and stay out of the hospital. So I will hand it over to Dr. Gray to describe the project that was funded by the Bucksbaum Institute.
Thank you, Valerie. So I'll take a little bit of time now to talk about our project. As Valerie and a lot of other people have alluded to earlier today, with the advent of the COVID-19 pandemic, we've seen an explosion in telehealth encounters. And so while that has petered off some from our initial peaks in March and April, it's still settled at a rate that's about 38% times higher than our pre-COVID numbers. And I think Dr. Peak and Dr. Press have highlighted a lot of the care disparities that can come as a part of that, but it also left us with a really interesting opportunity of trying to find these unique and novel ways to get this education out to our patients. So in our project, our main goal was to try to identify how to get this education, how to provide these novel ways of education to our patients as an augment to their clinical encounter. And initially, when everything was pretty much telehealth, the thought was that that'd be augmenting a telehealth encounter. But then as more and more visits transitioned back to in-person, it was also about how to incorporate that educational component in a virtual fashion into the clinic, while some clinics were still facing issues with social distancing and not being able to have as many supplementary clinician providers in the clinic, or just the availability of other educators to come and be present in the clinic is always a concern, and time's always a concern as well. And so in order to study this, we really broke this down into two parts, a two-pronged project. So the first part is really highlighting the pilot aspect of this project. So feasibility. Is this possible? Can we integrate this virtual education into the patient encounter in a way that just works, just does point blank, it works, it doesn't work. And then the second part of this is really trying to understand the usability of this. So to make this a format that is useful for both the providers and for the patients, that makes them want to continue to use this. And so what works, what doesn't work, what could we improve with, in partnership with our COPD Foundation, the goal is to eventually have this as a program that can be disseminated on a large national scale. And so in order to make that possible, we need to make sure that it's something that's usable for all parties. And we did this, we evaluated this component, this was really our research part of this, by looking at providers of these multi-diverse stakeholders. With our clinicians, we sent them a survey trying to understand their previous use of telehealth and how we chose to implement this model. And then with our patients, we conducted semi-structured interviews after they completed their education, both on how their feelings of the education that day and with their prior experience with telehealth before this as well. So in the study so far, our goal is to enroll 50 patients. At this point, we've enrolled 10. I think no-shows have been our biggest barrier, which is maybe not a surprise to a lot of other people on this panel right now. But even with those small numbers, those 10 patients, we've seen some really interesting themes come out in both our clinician and provider feedback that we've gotten. And I think that a lot of those data will move forward. We just like to talk about some of those preliminary themes that we've seen so far. So the first of those looks at the pros and cons of technology-based visits. And patients, just as we as clinicians see benefits and negatives, patients see that as well. And we see a pretty even split between those who had negative feelings and those who had positive feelings, both in their prior experience. Again, this is before all of this, with phone visits or video visits as a part of their healthcare plan. Some people felt it was very similar, others felt it wasn't. I think that segues really nicely into our next theme that we'd like to talk about, which is what their preference is for their clinical encounter. And so overwhelmingly, we saw that the patients pretty universally preferred to be in person. No one thought telephone was comparable to an in-person visit. I think that makes sense to a lot of us. The feelings were a little bit more split when it came to video visits. And I think when we break that down a little further, we see that people who are coming for those chronic disease check-in appointments, they felt that they were able to get all those things needed to feel that they had a complete visit. But if someone was sick, if something wasn't going well, they really wanted that in person, they wanted that exam, they wanted those vital signs, any additional tests that might be done on that day to understand what's really going on with them. So universally, we saw that there's a strong preference towards in-person clinical part of the encounter. But when we then looked at the educational part, we saw that despite that strong clinical preference for in-person clinician visits, the virtual education part of it was really well received by our patient population. So we kind of broke this down into two groups. So of the 10 people, 4 of them had inhaler teaching before, and they felt that it was very comparable to they were able to go through the steps of showing their use, repeating it, and they felt that they again gained skills in that repeat, and that kind of ties back to Dr. Press's assessment of how we need those re-education sessions to really solidify that good inhaler technique. You might say that those people have done it before. So this is just reinforcing what they had previously and not necessarily teaching them a new skill. But of the 6 people who hadn't had inhaler teaching, they all additionally felt very positive about this. And many of them commented that they actually realized through the session that they'd been using their inhalers incorrectly up until this point. So they probably maybe never were using them correctly at any point. And so they learned through this. And I think that's a really positive thing to see, is that this is something that our patients are benefiting from in a way that's meaningful. So then we talked to the patients, and then it was time to look at our care team providers as well. And for this survey, we tried to get a lot of different perspectives. So we talked to pharmacists, social workers, respiratory therapists, APNs, and physicians to try to gather some of this data. And we looked at a couple different groups. We talked to our own care transitions clinic providers who are a part of this project. We talked to people in the primary care group. And then we also talked to people who we felt would be maybe more of an expert level of incorporating these multi-clinician visits, people from the pulmonary clinic and our COPD and CF teams who routinely, as part of the patient care, will incorporate multiple clinicians as a part of the patient encounter. And so what we saw, we've highlighted two of the questions that we asked them in this survey. And one is just, do you think this is helpful for the patients? And pretty overwhelmingly, we saw that people felt that this would be beneficial. Education, virtual education as an augment to their clinical appointment would be helpful to patients. I think the more nuanced question that follows from that is implementing this, is putting this program in place and utilizing this program, is that more cumbersome than helpful? Is it not worth it to you at that point because of all the other hassle that comes with it? And in that question, we saw a little bit more of a middling response, a little bit more of a neutral response. And when we break these down into the subgroups, it's actually really interesting. So the people who still felt very strongly that this was beneficial and that the patients, it was worth it. It was worth it to give this education session to the patients, tended to be the pulmonary providers who had more experience with those multi-clinician visits. The neutral category was largely made up of our primary care physicians who hadn't had experience, and some of our care transitions clinic providers as well who hadn't had experience with this. But when we looked at their qualitative comments, interestingly, half of them said, if this were in place, this is something that I would really be interested in using and be able to provide for my patients, especially certain subgroups of patients that really would benefit from that repeated education as well. And so, but they just haven't had the opportunity yet. And I think this really highlights the importance and need for this type of intervention, both for our in-person appointments, if they're not able to have those educators come to the clinic at that time, and for some of our virtual appointments. We don't want them to miss out. We have patients who are afraid to come to visit still because of COVID and other things, but being able to provide them this education as an augment to their clinical practice is really important as well. So now that I've talked a little bit about some of the data that we've gotten so far, I'm going to turn it back over to Dr. Press to talk some more about kind of what this all means and what we plan to do with this going forward.
Thanks, Dr. Gray. So thank you for presenting those data and for highlighting the focus of the project. So I think one of the exciting aspects of this is that virtual teaching can be a way to complement in-person clinical visits. Again, as Dr. Gray mentioned, we can't always have as many people physically present in the clinic, or some of our educators may not even be on site, or it just makes it more feasible to be able to do the teaching virtually. And so this was a way to test this kind of teaching, but not relying on patients to have all of the technology access and literacy at home to handle this on their own. So it was a really exciting way to do that. We weren't surprised to see some mixed feelings and even some preferences around having the in-person visit, at least with the clinical scenario. But we are very excited that patients found use of this educational strategy and benefits, regardless of whether they had been previously taught or not. And we're also equally thrilled that we're seeing a lot of clinicians showing interest in this, either through their existing experience and or open to having the experience. So much more to come, as we are only about a fifth of the way through our data collection, but already seeing very exciting themes. And in the future, we are moving forward both with this project, which is really helping to provide these insights, and we are hoping to understand further roles for telehealth. I think that we recognize there are both pros and cons of trying to get this kind of educational strategy in patients' homes in a way that is equitable and doesn't sort of widen disparities and gaps. And so there's effort underway through a recently funded R01 through the Agency for Healthcare Research and Quality to look at this in a very meaningful way to understand if and when and how we can use other non-healthcare settings, whether it's homes, community settings, et cetera, to help provide educational strategies and get individuals the help with the technology they would need in order to benefit. And we're thrilled to be partnering with the COPD Foundation to not only use their expertise during this process to understand with their access to a wide patient network and patient caregiver network, but also to then help us disseminate. And with that, if there's time, we'll take questions. Thank you so much.
Thank you very much, Dr. Press and Dr. Gray, for presenting your research. And I do have one question I would like to ask, and that's the length of time that it takes to do this teaching, either in person, with a patient, or when you're doing virtual visits. And how do you recommend a practitioner who's got a really busy clinic take that time to do this type of teaching, and how can we use our staff that we work with to help with these teaching programs?
It's a great question. So in a separate research study, we actually timed this in-person Teach-to-Goal. And for each device, it was around 2 to 3 minutes. So about a max of 6 minutes to do Teach-to-Goal back to back. That's in person. If you add a little extra time to set up the video platform so that patients can use that telehealth, it's probably a little bit longer and depends on the number of inhalers. We've been fortunate to test this in the Care Transitions Clinic, where patients can be moved from their clinic visit room over to a more common space where we can actually provide the education. We are, part of the reason we're talking to clinicians at our institution is to understand how we could then feasibly integrate this into a clinic setting. There are opportunities to think about, sometimes patients are brought back to their room after they've gotten their vitals, but they need to wait a little bit for the time to see their clinician. And that could be a time that we use. Pre-pandemic, we did actually partner in the pulmonary clinic with pharmacists to provide this education. And then I know that the refractory obstructive lung disease program led by Dr. White and Dr. Narakis did also partner with Ethan Israelson, who is a social worker trained in this. And they were able to kind of utilize the room already be taken by that patient to provide this education, sometimes before the visit and sometimes right after, before they transitioned. It is tricky and space is at a premium, especially in these pandemic times where we're still social distancing at times. So we are working on that. That is part of the data that we're hoping to collect. So thank you.
And then Dr. Sorrentino, just to kind of comment on one of your other things, the concern of clinic flow. I think that's kind of the heart of what you were getting at. And that is one of the things that in our care team survey, we saw providers talking about, especially in how on certain days that may not be possible. And even for the patients may not be possible if they have a pace ride coming or someone to pick them up and things like that. I think a future method to explore some of this is looking at, we have to be careful with our language, but using separate clinical appointments as well. We talk about synchronous versus asynchronous, but then that sometimes people think that's synchronous or asynchronous with the patient, but we are speaking to it as synchronous or asynchronous with the entire care team. And so there are places like at the University of Michigan where for their CF team, they felt that they weren't getting enough time for each of those things. And so when they're incorporating some of these virtual stuff, they've actually scheduled in the like Epic Encounter, they'll schedule separate appointments that are virtual. So the patient doesn't have to come back to clinic necessarily, but they could get that extra education separate from their initial clinical encounter, but it'll be something that is an appointment. So it's not just someone will come and call you at a certain random time. It's a little bit more structured and scheduled to allow them more time to do that if it's a day where time is not possible.
Well, I want to thank Dr. Press and Dr. Gray for telling us about innovative ways that we can really approach teaching our patients. I think this is a great step and can be clearly advanced to many other things that we need to teach our patients about.